All right. Good afternoon and welcome, everybody. We'd like to extend our warmest welcomes to everyone who is joining the National MHPA webinar. This afternoon, it is entitled Connecting Care, Virtual Solutions for Chronic Maternity and Behavioral Health Challenges. My name is Shamit Luhar, and I'm the CEO of Vheda Health. And joining me are two of the key experts in our field. The first is Dr. Jones, Senior Medical Director, and Amy D. Dominicus, the Vice President of Clinical Design and Development. And before we dive into our discussion here, I thought it would be really great if we could anchor the discussion with just some of the key points that we're seeing in some of the national statistics. So, Dr. Jones, would you mind sharing the top two or top three metrics that really illustrate the urgency around chronic maternity and behavioral health? And for those of the folks who are on this webinar, all of our health plan leaders, can you explain why you're picking these two or three metrics, and why is it that we're choosing to highlight these specific metrics as it relates to chronic maternity and behavioral health?
Good afternoon, Shamit. Thank you very much for that question. I'm happy to be here along with you and Amy. When we look at maternal health outcomes across the country, three things or metrics stand out and frame the urgency of the need for integrated care. First and foremost, 80% of severe maternal mortality and morbidity occurs in a woman who has at least one chronic condition, such as hypertension, diabetes, or obesity. And a growing number of women also experience behavioral health changes. We know that 1 in 5 women will have some type of perinatal mood disorder or anxiety. And the rates are even higher when women are managing chronic health disease along with their pregnancy. And we also know that in rural and underserved communities, these risks are double. Maternal behavioral health is the leading cause, or one of the leading causes, I should say, of maternal morbidity and mortality. Approximately 22% of the pregnancy-related deaths are due to women who have behavioral health disease. Secondly, the way we deliver care. There's fragmentation is what's driving utilization. And when you look at behavioral health in a silo, diabetes and glucose control in a silo, blood pressure, and if these things are managed separately, these women experience poorer outcomes, more ER visits, more hospital readmissions, and missed follow-up with their healthcare providers. Also, what is important is the postpartum period. The postpartum period, the holy grail, and that's the system's weakest point. How do you engage women after they deliver? Most preventable deaths occur after delivery, when traditional coverage and clinical focus tapers off. But if we integrate chronic behavioral maternal health, we identify risk factors, we intervene more effectively, and we can support both the mother and the infant's outcome. So for health plans, it's not just about health outcomes, but it's about quality of care and compliance.
Yeah, no, thank you for that. And you said one of the many key topics I think all health plans, particularly the leaders that are on this call, are focused on, which is outcomes. And you highlighted a number of key national statistics, but you're an OB, in the state of Florida. So maybe you could, highlight how these statistics, relate to the work that you're doing in the, in the state? Or is it better? Is it the same? Is it more challenging? What have you seen?
Well, what I've seen as a clinician
Hmm.
is it's more difficult. It's more difficult for us to connect the dots. It's hard to bring this integrated care to bear. We've got, like I said, mental health here, chronic health here, and we can't get patients together. So from a clinician point of view, if there was something that could connect the dots, that would improve outcome from a clinical point of view.
Yeah, and is connecting the dots, is that particularly challenging because the patients that you're seeing, they live, all across
Yeah,
the panhandle
yeah.
of Florida? Is it because
Hmm.
of that rural access or
Yeah.
lack
So
thereof?
So access to care, yeah. So it's a combination of siloed care and a combination of access to care uh, in rural areas and even in urban areas. We have access to care problems. Patients might live in areas that they don't have good internet access, for instance, or good transportation. They live far from hospitals, they live in an urban area and it's still a OB desert
Oh,
because
yeah.
the providers don't take their insurance. So there's a combination of factors that uh, lead to this sort of fractured care.
Yeah. So, that fractured care, it seems like, one of the leading causes of that fractured care, as you mentioned, is that access to care barrier, right? And if we could just provide our moms with that easy access to care, you would have the ability to not only connect the dots, but then from the health plan's perspective, achieve the outcomes then as it relates to both compliance and quality performance, right?
Absolutely. That
Yeah,
just one leads into the other for the healthcare plans.
yeah.
And for the healthcare plans, it's not just a care issue. Like for me, it's a
Mm,
care issue and I want good outcomes. For the health plans, it's a compliance and financial performance issue, as you said.
mm,
So the same metric that define quality and reimbursement, like the HEDIS prenatal postpartum care, prenatal depression screening,
mhm.
blood pressure control,
Yeah,
hemoglobin A1C. Uh, that depends on this seamless coordination of care across maternal, behavioral, and chronic health. And when those touch points don't happen, which is I think 90% of the time, I might be exaggerating, but in my world, it feels like 90% of the time,
yeah, right.
those things don't easily coordinate, right? So when
Hmm.
these touch points break down, it really directly impacts these quality metrics and lower quality scores for the healthcare plans lead to, bonus, affects their bonus, withholds, etc. So
Yeah.
it's imperative that uh, we find a model that helps close these gaps and
Mhm.
integrates, you know, uh, all aspects of the woman's life.
Oh, absolutely. And I think earlier this year, one of the things that we did is we highlighted and led an educational webinar that was focused on boosting health plan quality ratings.
Mm-hmm.
And it was in that webinar where we really highlighted many of the HEDIS measures, for example, that you outlined, and how by not hitting those, these our leaders may not be able to obtain many of the bonus payments or quality dollars that they would otherwise be able to acquire, which for a health plan could essentially make or break their year, right?
Exactly.
Yeah, yeah. Okay. Well, one of the things I would like to do is, you started taking us down an understanding of the care gaps and why it's so critically important to achieving that access to care focus and ultimately the clinical and quality performance. So,
Mhm.
why don't we revisit a little bit and, specifically from the perspective of these care gaps, why do these care gaps continue to persist for our members that are polychronic, right? They are maternal health members with multiple chronic and or behavioral health conditions. And, let's take a focus specifically on those moms that you were talking about, right?
Yeah.
Those moms who are high need or in OB deserts, if you will.
Right.
Tell us about that.
So, you know, it's a $1 million question, of course. Why do these care gaps still persist
Yeah.
despite, new mandates, despite, ACOG, that's for me,
Mhm.
ACOG, Society of Maternal Fetal Medicine, guidelines, insurance companies, you know,
Yep.
instilling mandates, the state mandates. Why do we still have persistent gaps in health care? And it tells us that policy, because this is all policy
Yeah.
that we're doing, alone can't overcome persistence in gaps. We have to think out of the box,
Mhm.
especially in areas, as you said, Shamit, rural and high need communities when there's simply not enough providers, no behavioral health provider, no OBGYN to meet the demand. And in communities where there's no broadband or
Right.
limited broadband, um, how can we ask patients to be engaged when it's impossible for them to go to their doctor? They don't have a reliable phone service, either because of their personal broadband issues or economics. It's
Mm.
not cheap to have a cell phone.
Sure.
um, yeah. And then, systems remain siloed. I have my OBGYN chart, behavioral health has theirs, chronic care doctors have their own systems and silos that they're operating, and we do not talk the way we should. And this fragmented care leaves mothers, especially those juggling multiple conditions, without continuity or consistent follow-ups. Um, Even when we have mandates that say we should screen and coordinate, uh, it falls short
Mhm.
many times. Uh, so in order to get real equity and close these gaps, you need continuous connected support for these mothers, somebody who's there throughout their pregnancy and beyond. Programs that bridge, or like you like to say, Shamit, connect the dots
Mhm.
through combining integrated technology, whole person care, like thinking of the mother as a whole person, being aware of her social needs, um, her mental health needs, her obstetrical needs, and real time connected support, and data for the insurance company, real time data, so that
Yeah.
we can prove that we're closing the gaps, and a system that can do that,
Yeah.
and is a system that's potentially going to significantly close the gap and improve equity in obstetrical care for women.
Yeah. And there were a lot of wonderful um pieces of information in what you were saying. And, one of the key messages that I think all of us can take from this is that our moms are are experiencing healthcare in a very fragmented, unaligned way, right? And so as
Absolutely.
you think about that as a health plan leader, that's probably why we see engagement rates for our moms not as high as we would like.
Mhm.
Delivery costs for those moms are going to be a lot higher because those moms are not receiving the care at the right time, which would prevent, let's say, a NICU admission or even
Absolutely.
a a hospitalization or ER visit. And I think there's just better things that are out there that could pave the way, if you will, to the outcome, to the quality and the clinical outcomes that you were talking about. So
Yeah.
again, yeah, I think it really just comes back to connecting the dots,
Yeah.
right?
And like you said, those clinical outcomes,
Hmm.
that's what health plans are judged on.
Right.
We're all, they're judged on the clinical outcomes of the patient. The better the clinical outcomes, the better the scores, the better like you said, the admission rates into hospitals and
Right.
ERs and
Mhm.
preterm birth and hypertension. Uh, it improves it if we can
Yeah.
if we can support and connect our mothers. That I think is the best. Um, I have a story. I'm not sure if I've told you this before, but we have in my office we have a woman
Mhm.
who does that. That's her 24 hours, 7 day a week job, is to connect the dots. It's hard work,
Mhm.
but it's essential work, you know. And if you anything that you can find that will help you connect those dots for the patients, it's invaluable. Really
Yeah.
is.
No, for sure, for sure. So it's, how do we get from a state of fragmented care, right, to unified and integrated care? And I think
Absolutely.
Amy, that's where integrated member journeys, right, are very powerful for our health plan leaders. And I think it'd be really great if we could, highlight, from your perspective, what you've seen as a unified virtual model for members, specifically, our moms, as Dr. Jones has described, that really helps elevate the engagement, but then also by creating those higher levels of engagement, driving better clinical and quantifiable delivery cost improvements, for those moms, which, for the health plan would translate into higher compliance, bonuses, and even results that they would be proud to share with their Medicaid directors or even their peers at other health plans. So, what does a different unified virtual model really look like?
Yeah, so I mean, I think there are so many things I can think of right off the bat.
Mhm.
But if we think about one of the things that Dr. Jones mentioned repeatedly,
Yeah.
which is the disconnect, the
Mhm.
siloed care and the lack of, interdisciplinary or integration, that really helps to thwart what the system should look like, right?
Mhm.
So if we look at our integrated care and really want to understand, how members look, as a virtual model. What we're looking at is really starting with a simple digital engagement. So every member would receive, a provision smartphone. It would have the remote monitoring tools and, health plan specific programming. They would have things like scales, a blood pressure cuff, glucometers, and these tools or these devices are prepared, so they're ready to use. The members, and one thing we are really focused on doing upfront is to remove some of the digital or access barriers, right? So we want to drive that engagement. We want to make the care consistent and accessible for members. And really the program focuses on engaging those members,
Mhm.
and making sure that they're able to have that personalized experience. So really, there's a blueprint. We work through daily monitoring, automated reminders. It could be live support. And it's really designed for members that need that behavioral risk or a chronic condition, or maternal milestone. And really overall, I would say population health and preventative measures feedback.
Mhm.
Um, it has screenings where initially members are screened through behavioral health so that your PHQ-2, PHQ-9, EPDS. We're able to stratify things like race, ethnicity, language, their geography, and really escalate care for our high-risk events or TMAH requirements. Really, the thing to also think about is the mobile first option. So being able to use the multilingual design, we really have an opportunity to bridge gaps with the digital deserts, providing turnkey technology to people who've never had it, and ultimately providing, something that we all struggle with wherever you are, which is connectivity, right, and access. Members do receive, a kit with no setup that's required. And this deployment makes things rapid and scalable. We talk about in healthcare that it's the whole person. So looking at, social economic or SDOH risk factors. And that really feeds into the member level data workflows. We're really working to support those HEDIS measures. They're specifically for maternity. I think about the perinatal or postpartum metrics, the interventions that we can tailor to help address the barriers. Members that we can work with might experience barriers that deal with transportation or food, language services or things with digital access overall. Maybe they've never used equipment like that. So, if members are participating and things shift, we really have a system that's in place and intervene and can coordinate with members and their care team, because that is so important to close that loop or connect those dots, as we keep saying. Trying to really prevent avoidable situations or worsening situations or utilization that ultimately would drive these, these member or clinical even improvements or outcomes.
Right.
I think, that program simplicity and personalized care helps to work with proactivity. We're able to turn what I think is equity into measurable outcomes. So our higher engagement reduces avoidable use in a hospital setting and has stronger quality performance and care team collaboration. And this is really what I would consider equity in action every day for our members.
Yeah. One of the really key things that I want to make sure everyone heard from what you just shared is, in order to connect the dots for our members, one of the essentials that we must solve for is simplicity. And so what you outlined there for our members, it really starts with them and making the whole process simple for them, because it's already fragmented. And so you highlighted a number of things, everything from, I think our health plan leaders, on the phone, they may have scratched their head for a second, like, man, I never thought about giving or providing a fully provisioned smartphone, to a member, in an OB desert. But it kind of makes sense now, because in an OB desert, that mom probably doesn't have either access to the right broadband service, or she may not even have access to the right OB provider. And this helps them overcome and gives them the tools to empower them to manage that pregnancy. And so by doing that, it seems like all the other things naturally may start to fall into place, in terms of the mom is now able to receive the education that she needs. She's now able to receive the depression screening that she needs, and she's now allowed to have and receive feedback on whether it's an elevated reading. If she is managing her preeclampsia, those blood pressure readings, if she has gestational diabetes, ensuring that blood sugar is in line, and doing all these other smaller things behind the scenes, such as looking at their transportation, adapting to their local language, doing all of these things in the background, it creates the ability for the member to say, hey, the health plan's got me, right?
Yeah.
So, Amy, one of the most powerful things about healthcare is people, right? That's who, ultimately, who we're serving, who we're empowering, every single day. And I thought it'd be really wonderful if you could walk us through a member story, that kind of walks through this live unified model of care that we were just talking about, right? And explicitly, if you could talk through some of the stages, from what the health plan wants to achieve to the outcomes that they can expect. I think that would be something that would be really powerful for this group here.
Yeah. So, what we're able to show is really, if we took a member, for example, a mother or expectant mother who is middle-aged, so 35 years old, let's say, a new mom, maybe she's managing chronic conditions like diabetes or hypertension and eventually postpartum depression. You know, what ways does the program or Vita support this member? And I think when we start off, even from the beginning of identification, so how do we identify and enroll members? This could be a member that's flagged through referral or claims or a social risk or risk assessment. This member could meet criteria for your high risk maternal engagement and be someone to consider. Once we have that member identified and enrolled, we would onboard that member. So, whether it requires, as we talked about before, a multilingual kit or certain devices related to her conditions, it would be, live support and immediate digital access for this member. As we mentioned, for the behavioral health or EPDS or, condition specific devices. There would also be integrated monitoring. So, daily monitoring through the app as well as the devices and mood check-ins. So this would be an area where the program could really track not only compliance, but some data feedback. So, if we need a PNDE dashboard or if a member's vitals or moods look abnormal compared to their baseline. This is something that we can escalate within minutes, being able to see that and see how the member behaves and when there are changes in those behaviors. And this would really, in my mind, lead to what's most important, which is timely intervention impact. This is where we would potentially prevent, unnecessary ER utilization, saving upwards of 35 to 40%, and cost per member per day is very expensive when you're admitted. So thinking about that, and then preventing behavioral health or maternal health cases from becoming a crisis. This could be not only an inpatient admission, but have subsequent issues involved. And we look through not only the patient through their condition or pregnancy, but postpartum. We know that states are changing, CMS and TMH requirements, and that equity stratification would be involved. So, our postpartum care completion rates are over 83%. And this really ties directly to the payer quality bonuses. So your NPS scores, we have a rate of over 50%, and it really supports not only member satisfaction and retention, but star ratings for the health plan. As a clinician, what stands out for me, and I'm sure Dr. Jones can relate to this, is the collaboration and getting information to the right person at the right time. So being able to share these readings or this intervention or this concern with a member's OBGYN or potentially postpartum their PCP when they've transitioned, behavioral health provider, whoever it may be. And it really helps to enable stratified reporting and bonus eligibility. But ultimately, the bottom line is being able to turn what I think most clinicians would consider, high risk maternal care into more proactive and measurable outcomes for the plan, but also ultimately the member doing better and their child, because now we have two lives, right? So that to me is the win, is being able to set people up for success and sustainable, healthy habits for even more than just the member, right? So it's themselves and their child and or family that they're learning these behaviors for.
Definitely. So, for what you just shared, it's, how do we put a model of care in place that's available to ensure we have a healthy mom who delivers a healthy baby, right? And many of the health plan leaders who are on the call this afternoon, I think one of the things they may be seeing is there's a lot of unity, right, in this member journey. And what we want to be careful of is not to stitch, many different models of care together, hoping that we're going to get and achieve the outcomes that Amy, you just talked about, because there's a whole system that is set up that has to be unified. It has to be working, and especially all the cogs have to be turning at the same time. And if all it takes is essentially a single point of failure where that, that PM savings or that ER visit impact percentage that you outlined could more than double. And so one of the things that our plans should really be focused on, right, is what are the models of care out there that, essentially provide scale, right? They help us address all of the pain points, everything from the identification, enrollment, and onboarding to the check-ins for our members, which then ultimately lead to the impacts and the collaboration for our providers, so that our moms deliver a healthy baby. So what we would like to do now, I think this really sets a really beautiful stage for us. So what we thought would be amazing is to share the story of a new mom in a scenario like the ones Dr. Jones and Amy have been describing. And like many moms that we see in our various programs, it's always about moms who are in the early motherhood. They're trying to figure out, how do I secure a car seat for my baby? How do I ensure that I have transportation to my medical appointments? How do I ensure that I have a provider who can provide me access to the medications that I need? And so, you take these things together, combined with the fragmentation of our system, it's just overwhelming and it's hard to access, right? And so what you're going to see in this demonstration is how the virtual care model that Amy just described really addresses all of the key points here, but does so in a way that creates unity for the member and also results in an empowerment. And so you're going to see that now.
I'm excited. I'm happy about the baby, but I'm feeling super tired, and then I'm feeling a little bit down.
That's completely understandable. So, adjusting after delivery can certainly be overwhelming. And I did notice that on a few of the assessment questions, you indicated that you might need some extra support. One of those was about getting to and from your appointments.
So transportation is an issue. It's my biggest issue right now. Before I had the baby, it was getting a car seat, but they helped me with the car seat. But I'm still having issues with transportation, getting to and from appointments for myself and the baby.
Gotcha. Well, thank you for sharing that. And, Transportation challenges can certainly make everything a lot more difficult. I'm not sure if you're aware or if you've looked into this before, but there are transportation resources from the health plan. There's also that one-touch button on the home screen of your phone. But I'm happy to take you through those next steps. Is this your OBGYN? Are you seeing any other providers for your health or mental health right now?
So, to be honest, I haven't seen any other doctors outside of my OB since a little bit over a week ago, and I haven't seen a primary care doctor since before I was pregnant. So, no.
Okay, got it. So right now, it sounds like we need to find a new primary care doctor, and that transportation is a barrier for you. Any other challenges? Have you been having difficulty with any symptoms that you've been experiencing? Or everything okay? Do you have all your medications that you need?
So the doctor did say that, after a baby, a lot of things will be changing for me, but I really feel like I've been having a lot more anxiety, and then I can't really focus, and at night I'm unable to sleep even when I'm tired. But I was taking this medicine previously, and I started back taking it, but I only have a little bit, and I've only been taking a half a pill every other day so that I could not run out.
So we could connect over video right now. That way we'd be able to go over everything together. I could see the medication bottle, and we could look at the information.
Okay, that'll work.
Great. So if you just wait 1 second, you should see me calling and we'll be connected over video.
Okay.
Hi, Nicole.
Hi.
You see me okay?
I do.
Wonderful.
Look at your hair. It's nice. It's
I
pretty.
know I haven't seen you on video before. So, do you have the medication bottle with you? That way, if you could just hold it up to the camera on the phone, I'd be able to take a look at what it says.
Okay, so got it out just for you.
And if, a little closer for me, just a little bit.
Oh, okay.
That's perfect. Okay. So it looks like you're taking a citalopram, and that's a crazy hard word to say, but it's also called Lexapro. And it says you have 10 milligram tablets that you're supposed to take once a day. This to me is just another reason why we need to make sure you have a primary care doctor, if that's who was prescribing it before. So we can certainly work on that today.
Okay, yeah, so what would be the next step to work on that?
So first, for the medication, we could call the pharmacy because it looks like you have a refill left.
Okay,
So we could call together. If you know how to do that, you could do that on your own, and we could get the refill, or at least start there. Then we could call member services together. This would be a way that we could find a new primary care doctor in your area. And after that, we could certainly work on transportation, once we have that provider and can schedule an appointment.
yeah, that would be helpful, because I really want to work to get these things on track.
Perfect. So, not just this medication, but any medications, you'll get an in-app reminder before you run out of your medications. So that might help too, if you're having trouble keeping track of things.
Yeah, because it's just a lot to deal with, especially with the baby and this life. So this will really help me.
No, I'm happy we connected today. And so we're going to get started. I'm going to put you on a brief hold. We're going to call member services together and we're going to take care of this.
All right, thank you.
All right.
This interaction between Amy and one of our moms to be, this is a scenario that Dr. Jones, you probably see day in and day out in your practice. And for the health plan leaders that are on the phone today, this is something that that you're hearing and you're experiencing. When we were listening to Nicole, think about how overwhelmed she was. She was thinking about that car seat. She was thinking about her provider. She was thinking about her transportation. And as Amy was walking her through each of those pieces, you saw a sense of calm and assurance and empowerment that came to her. And that's really what a unified care model can do, right? It's not just focusing on the transportation issue or ensuring that working with the mom for the provider access. It's working on all of them together. Amy, you said this earlier, around the whole member, whole person care. And that's what we want to strive to do, because ultimately that allows us to, what we like to call at Vheda, closing the loop, right? Looking at everything from the mom's and the baby's health to the provider needs, transportation, behavioral health, and even chronic condition management. And so we're slowly moving away from that fragmentation and creating a unification model that connects the mom with the resources that she needs at the right time so that she can deliver that healthy baby. And so, Dr. Jones, we've heard a lot throughout the webinar as it relates to this unified model. Could you highlight for us, how are behavioral health, equity, and even access to care woven together, especially for those who are in those OB deserts or those rural areas? And Dr. Jones, I don't believe we can hear you.
Thank you, Shumi. I was saying it's the demo is a very powerful illustration of how equity works and what equity is all about. Not just access to healthcare, but equity. And Shami, you said something also that I think kind of also speaks to equity. We're in the people business, right? That's what we do. We're in the people business. And if you, Amy, in this demonstration, treated the mother as a family member, as she would have helped out some friend of hers. And that's really what patients are looking for. They're looking to be seen, to be heard, to be treated, and to be helped. Equity shouldn't be an afterthought or some kind of, fancy word, equity. It's just us giving good care to people, care that every patient should get. At Vheda, as the demo illustrated, it's foundational. It's what the foundation of the program is built on, is equity. Listen to the mother first. What are her needs? What are her concerns? Screened her for her medical risk, her behavioral risk, her social risk, and then connect with her in a very flexible way, the way she wanted to. First a phone call, then be able to go to a video chat. If she wanted to text message throughout the app instead of a video connection, the app has the capability to do that. And as you asked me about rural and underserved populations, this is crucial for good continuity of care, closing gaps, improved health care, improved outcomes. For, as Amy said, we're not just here for the mom anymore, we're here for mom and baby. And this kind of integration and this kind of equitable health care will improve that. Having the cell phone available, simple, easy, just open it up and you're connected to somebody. These are all very important factors in maternal outcome. And as you see, supporting her postpartum, it's not good enough that we got her to 39 weeks and she delivered her baby and they're both healthy. This member is having real health challenges postpartum. And it was so important that she had the availability of a program that reached out to her in the postpartum period and held her and are continuing to help guide her to the appropriate healthcare providers that she would need so that she would have a good postpartum outcome. Her child will be better cared for if the mom is cared for. It adapts to the woman's needs and meets the woman exactly where she needs to be met. Every individual as an individual. But you said it's simple. We're in the people business. This is what you would do for your mother, sister, aunt, cousin.
For sure. So what it sounds like what you're saying is that for our moms or even, any person, is that everyone deserves access to care, right?
Anybody, yep.
Yeah.
Not just access, because you have a health insurance, you have access. You have to have equitable care. It's really important that there's a big difference to me for access and equitable. Everybody has a little different need once they have the access,
right.
And you provide that extra.
Provide and adapt to it.
Provide and adapt to the need of that individual patient, and that's crucial.
Yeah,
in a caring and loving manner.
Yeah, that
again, crucial.
That individualization and customization, meeting the member where they are, that's a very powerful thing. You're right, because our mom Nicole, she may need something slightly different than, let's say, our mom to be Mary or Tracy or somebody else. So absolutely right. And so let's take this one step further, right? We've been talking through a number of the from a capabilities perspective,
right.
how we connect the dots. But how does connecting the dots, as we were saying at the top of this webinar, translate into quantifiable outcomes? And so let's talk a little bit about those results. So what does it mean, from the perspective of that are dollars saved, improvements in care gaps, even device compliance, and what we were just talking about, equity?
Yeah. I asked the audience to take a look at the slide here. It sort of sums everything up. It proves that integration delivers measurable value. Having looked at thousands of Medicaid members, specifically in disadvantaged zip codes, you can see here that there's a 80% device adherence and up to 70% in behavioral health engagement in 1 quarter. There is a significant decrease in total costs, up to 20% in the cost reduction. The ROI up to 5.1 to 1 for maternity programs. And you also looked at the ROI for chronic disease management, which is 3 to 1 to 1. The emergency room visits is significantly decreased, up to 22%, 11.5% fewer maternal admissions, which is wonderful. Pregnant women are not supposed to be in the hospital unless they're birthing their babies. So that alone is a standalone figure. And of course, the driver that decreases your NICU admissions is the fact that up to the average gestational age of delivery is almost 39 weeks. And when you map to the CMS and TMH model, with the extended postpartum engagement and behavioral integration and equity improvement. It will significantly improve HEDIS scores, and it's proof that the whole person continuing care is not just clinically effective. And you know, I have a bias. I like the clinical effectiveness side of it, but it is financially sustainable because you have significant reduction in cost. And again, because we're being judged now on equity, accessibility, and clinical results, it also improves, you know, the financial sustainability of programs such as this.
I see. Okay. I think that is very, very impactful storytelling, you know, for a model such as the one that we're talking about. So I know we're, you know, almost close to the top of the hour for this webinar. You know, would like to spend, you know, just a quick minute here, just talking through, you know, this virtual care model and, you know, just some of Amy, your thoughts real quick on the how the program model aligns with ACOG guidelines.
Yeah, so when I think about some of the program flexibility, really the program is able to configure whether it's, I mentioned before, demographic or clinical assessments, onboarding assessments, and ongoing, or analytics. And we can adjust with ACOG. So when we look at the CMS and really the NCQA standards, you know, postpartum care I already talked about. So the postpartum care and visits, but we're able to roll out changes really across the platform or member cohorts in real time. So if there is something that needs support, members can stay supported beyond the traditional window. So if there are, you know, goals for certain other preventative measures or gaps, it could be a flu shot or some sort of screening that really is the most important. The adaptability, in my opinion, also extends past that. So it would be, you know, even for reporting, you know, and the analytics portion of that, which again, I feel silly saying this, but I'm in the human business, but the reporting matches the activities from a clinical and coaching perspective and wellness perspective.
Sure.
And I think that's one of the things moving forward, really being focused not only on what we're doing, but even before that, looking at predictive models. You know, and these would include, you know, behavioral health or social data and demographics, and really just being able to anticipate risk. So I think that's something to really look upon for, you know, some of the transparency that I think the program provides that isn't provided elsewhere. It's really about keeping pace, you know, with the industry and with our members. So that's something I think is worth really kind of highlighting. The other thing to consider is making things personalized. So, you know, we keep talking about, you know, total member or treating the member where they are, but this really is about keeping pace with the evolving expectations and the integration of equity. And realizing, as we keep mentioning, and I hope the demonstration explained with a specific member, it is about the specific member. There can be generalities, but this is where I believe the integration and equity meet, and we're able to really treat the real person, right, at the right time with the right needs and support. So I think that's something really important when we think about ACOG or any type of score or stars to point out.
Yeah, it sounds like, you know, as we look ahead, you know, what you're sharing with the group here is that it's moving from prevention to almost being more prescriptive, right? And essentially identifying ahead what is likely to happen and taking active steps in preventing those future events before catching them before they even happen, and working to make those maternal health outcomes, whether like the ones we talked about, NICU stays, low birth weight, primary C-section, cost, all something of the past, right? Yeah.
Agreed.
Yeah. And, let's, we've heard a lot of great information here, during this webinar. I would like to ask, Dr. Jones, specifically to you, what's one piece of advice that you would share with our health plan leaders that are on the call, who are focusing on, helping moms deliver healthy babies?
Yeah, Amy said it so well. Um, uh, it's meeting every member where they are. That's one, and then the holy grail would be the predictive models, screening people, and risk assessment, and finding ways to prevent poor outcomes. So if we can have a model, and I think a model would be a virtual equity model, looking at the patient through the lens of equity, we could predict outcome and take steps to prevent poor outcome. And that would be a win-win-win, a win for the healthcare providers, a win for the patient, a win for insurance companies. So if we can find ways through technology, I think that would be like I said, the holy grail is to prevent the bad thing from happening before it happens. And that's
Right.
what medicine is all about. It should be about,
It is.
trying to
Yeah, and
identify the patients.
yeah, definitely. I think there's something very profound that that I heard you say a couple weeks ago, which is, I've never met a mom who never wanted to have a healthy baby, right?
Never, ever, ever.
Yeah. And I think that sums it up right there.
Yeah.
So with that, I would like to thank everybody for joining our webinar today. And, as a little bonus for attending, we'd like to invite all of you, if you haven't already done so, to obtain a checklist for our health plan leaders. And we really think that this is a very useful tool that will help you spot the right care gaps, strengthen your virtual healthcare program into one that goes from unification, from fragmentation to unification. It really provides some really nice guidelines to go along with it. And you can obtain a copy of that list by scanning that QR code that's on your screen now. And thank you again to Dr. Jones and Amy for joining the webinar. We really appreciate your insight into maternal health. This is something that all of our health plan leaders on the webinar today are really focused on, and I think we're leaving today with some really important ways that we can take our maternal health programs up a notch and really help produce stellar outcomes for not only our moms, but for our babies and for our health plans. So with that, thank you very much and have a good day.
Thank you, everyone. Take care.
Thank you.
Thanks.